Okay, I'd like some audience participation. What do you guys think about, this was a young male who presented with abdominal pain. Any thoughts? So this was read as, there was a cystic mass in the pelvis. It would look like it was posterior to the prostate. So one thought was, is it arising from the seminal vesicle? Is it arising from the rectum? So there was some focus on the cystic mass. What's a little bit harder to see initially is that all of this is also mass. There's all this mass here. It's a non-contrast exam, so it's a little hard to see. But, the bowel is up here. It's nicely opacified with contrast. And all of this is basically extensive sort of peritoneal disease. And then there's this big kind of mass here as well. And then this cystic component here. So the patient came for an MRI. And this was the MRI. So we can see that there is that cystic mass here. We still don't know what exactly this is, although I think it's part of this whole process. And then you can now nicely see all this like evil gray of tumor of like peritoneal carcinomatosis in the pelvis. So we definitely thought this looked malignant, and it went for percutaneous biopsy. And hold on, I'll just show you the post-contrast as well. Oops. You can see that it's, very avidly enhancing. And this came back desmoplastic, small, round blue cell tumor. So I did not really know much about that. I've heard about small, round blue cell tumors before, but just wanted to give you a couple of points about it. I think that the main point here is this is definitely malignant. It needs a biopsy. You're probably not going to give this specific diagnosis, but desmoplastic small round cell tumors are called DSRCTs. They're a type of sarcoma, which makes sense. This was a young patient. This looked like a very aggressive process. It usually develops in the abdomen or pelvis, and it's usually in young males between the age of 10 and 30. So, and also in white teenagers. So I don't know why there's a particular predilection there, but that's what the Memorial Sloan Kettering site says. They basically said that they were the first to describe this tumor in 1989, and it has a unique genetic defect with this. And our pathologist actually tested for this gene, and that's how they were able to definitively diagnose this as a desmoplastic small round cell tumor. These are treated with chemo and radiation and sometimes immunotherapy. So this was just an interesting case, a little bit tricky to see it on the CT because it's blending in here. But just, like all this obliteration of fat planes and stuff, you should think about an aggressive process. Any questions? Okay, I'm going to stop recording first. Okay, this is my next case. I do want some audience participation. So this was a youngish female. You can see that they have a fibroid uterus, and they had bilateral adnexal processes. So this is the right side, this is the left. You can already see that there's some, kind of suspicious nodular component to this in this adnexal cystic process. And it almost looks tubular with like half septations. We're wondering if this was a tube with some solid components to it. This was the pre-contrast. Left side, right side. So what do you guys think based on this pre-contrast?
Pre-contrast, it's bright then. So is it like some blood?
Yep. So very, very, very bright on T1 pre-contrast. So some kind of repeated hemorrhage. And that same bright part on the T2 sometimes is bright, but sometimes becomes darker, which we call shading. So what do you think these bilateral?
So it's like endometrioma and like.
Yeah, exactly. This is a very, very good look for endometriosis bilaterally. So really T1 bright, multiple, so a multifocal process. On the post contrast, it looked like this. So a little hard to tell if there's any enhancing components. We need our subtractions. And then this is our subtraction. So on the right side, we can see that there's enhancing nodularity here. And then on this left side, we see all of that papillary stuff is enhancing. So we were concerned about malignant degeneration within bilateral endometriomas, this one possibly within a tube. So do you guys know what malignancies arise in endometriomas?
Endometrioid carcinoma, I think.
Yes, excellent. So endometrioid carcinoma is the most common, although it's rare to have malignant degeneration. Whenever you have an enhancing solid component, you should think about, we can't exclude malignancy, and this looks very, very suspicious here. And then a less likely one that you can get is clear cell carcinoma. So endometrioid carcinoma, the reason it's called that is it resembles the glandular appearance of endometrial cancer. Although it is an actual ovarian epithelial neoplasm. And it's also associated with endometrial hyperplasia and endometrial carcinoma. In this case, we looked carefully at the endometrium and it looked pretty good. We did not see any additional cancer within the endometrium. This patient went for a hysterectomy and bilateral self-injectomy oophorectomy, and this came back endometrioid cancer bilaterally. It was FIGO grade 1. They actually called the cancer, it was pretty extensive. So it was extensive endometriosis with borderline endometrioid hyperplasia and then areas of actual endometrioid carcinoma. But FIGO grade 1 because it did not have a large soft tissue, the actual invasive part wasn't large. So it was just a really beautiful case of malignant degeneration within bilateral endometriomas. Any questions? Okay. Okay. So, oh wait, is that Joe? Is that Joe, my former fellow?
Yeah, hi Aarti, it's me.
Hey.
I joined like last month, so really nice to attend to your cases.
Nice to see you again.
Yes, same here.
Now I know who I can quiz. Okay, so also would love anyone to speak up. So this was a patient whose bilirubin was elevated. You can see that their bile ducts are dilated. And as we came into the hilum, the bile duct kind of disappeared. I'll show you the coronal. Oops. So what do you guys think this is?
Is it like we are looking at the Klatskin tumor, like which compresses over the hilum?
Exactly. So we've got biliary obstruction, abrupt truncation, and we've got this mass here it was about a 2 centimeter mass. It was not obstructing like the lower CBD and pancreatic duct were okay. Theoretically, I guess it could be arising from the upper pancreatic head, but it's basically essentially a Klatskin tumor causing obstruction here. So when we have a Klatskin tumor, I like to do something called think like a surgeon, and the surgeons, when they resect these, they want to basically remove the tumor and usually about half of the liver, whichever side is not involved as much. If we look at, this one is actually kind of low down, so it's nice. It's not like, you basically still have a maintained biliary confluence. But our tumor is here. And so you can see that the portal veins, I think, are away from it. It's not interfacing with the portal veins, so that's good. The main issue here is going to be the hepatic artery, because you can see that this hepatic artery basically becomes encased by part of the tumor here. But the cool thing in this patient is that it's hard to show this without you guys scrolling yourself, but the proper hepatic artery and the left hepatic artery get encased by the tumor, But the cool thing for this patient is that their right hepatic artery is actually aberrant, and it's arising from the SMA. And it goes posteriorly here and feeds the right side of the liver here. And you can see that this portal vein is actually protecting this right hepatic artery from the mass here. So in this case, the right side is protected. The right portal vein and hepatic artery and bile duct are also all not interfacing with the tumor. So the right side can be preserved, and they could do a left hepatectomy and remove the tumor. So that was one part of this case, which is staging the vascular involvement to see which side could be the future liver remnant. And then the other interesting part of this case is that there was a partially imaged pelvic mass. So if you saw this partially imaged pelvic mass, what would you think? You can actually just jump to, because we did end up doing an MRI on it.
Is it a female patient?
It is a female patient, yep.
Probably a fibroid.
Okay. So here it is. Dr. J says probably a fibroid. Any other, like, would you bring up leiomyosarcoma? How confident are you it's just a fibroid?
It looks like a degenerated fibroid, but I mean, you can't exclude leiomyosarcoma.
Okay. So exactly. So this is like the debate that we have all the time. Like, is it a leiomyoma or is it a leiomyosarcoma? And in this case, we thought it looked a little heterogeneous, but there are dark areas here. So I do want to show you this year in radiology, a consensus statement came out. Where is it? Here. So Nelly sent this to our group, but anyway, I'll just kind of summarize. Basically, their summary for this radiology paper, it's actually called consensus statement. They say, while rare, uterine leiomyosarcoma must be considered prior to leiomyoma surgery. And they give this algorithm. Can you guys see this? Is it big enough? Trying to make it bigger. I don't know. Okay, well, anyway, basically they say if there's any, peritoneal disease, highly likely malignancy. In this case, we did not see peritoneal disease. So then you go to the T2. If the T2 is intermediate or high signal, that's more concerning. If it's low signal, that's very suggestive of a leiomyoma, so that would be benign. This case, I thought the T2 signal was intermediate, so we're still going down, could this be a leiomyosarcoma? Then they ask you to look at the DWI, and they say if the DWI is higher than the endometrium, that's concerning. In this case, we could not even see the endometrium, it was obliterated by this mass. Then they go to ADC, and you're supposed to measure the ADC. If the ADC is very, very dark, it's more concerning for malignancy. And they give this number 0.9 times 10 to the minus 3. So if we go back to my case, we get the diffusion. Like I said, this DWI is not very helpful because we're supposed to compare it to the endometrium. And in this case, we can't really see the endometrium very well or at all. But this was the diffusion. Actually, this might be okay, this is the higher B value. So it's not super, super bright. It's kind of darkish. And then this was the ADC, not very dark. And when we measure it, it measures 1500. So that 0.9 number means that the ADC should be less than about 900 for it to be more concerning. So all of these features, according to this radiology
Sorry,
algorithm,
question.
Yeah.
Do we just measure the darkest area, or do we, you know what I mean? Like, because some areas are a little darker than others. Like,
1300. Nelly, nice to hear from you. And I was showing the algorithm from the paper you sent us.
oh, great. Yeah, no, it's great. I'm looking forward to this because I think it'll help a lot. And I'm glad that they incorporated DWI, unlike that other paper that we reviewed in abdominal radiology that didn't include DWI.
Yeah. And so I don't know, at least where I'm seeing the darkest is maybe here, or I guess maybe here, but that's just a tiny focus. None of them is measuring less than 900. Oh, this one's like close to 900, but it's just that small little area. Anyway, this was biopsied and it came back fibroid. So Professor Jay, you were right. We should have just asked you instead of biopsying it, but we had hedged on this, and statistically fibroids are much more common, but now we can also use this algorithm. I'll pull it back up, Nelly, if you have any other comments about this.
No other comments. I'm just glad that there's some kind of guideline.
Yeah. So it's interesting. So basically, we're just using the T2 signal. If it's T2 is bright, diffusion greater than the endometrium, and the ADC is pretty dark, measuring less than 900, we are more concerned for malignancy. Within 88 to 95% accuracy with the ADC map. So not bad. Okay, I'm going to pause.
Right?
Yeah, so I haven't fully looked at all the details of this paper, but they do reference that 88 to 95% accuracy for the ADC map. So they do seem to think that is a much more suggestive feature.
Because I'm going to start using that, and I just had a case not long ago where I more or less applied it, but I think having a pretty, especially if they're going to go after something and morcellate it or something like that, and whether or not they use the bag or not, it's important to know when it's, just a nothing burger, run of the mill leiomyoma versus something else that might, right? So I think including the possibility of a leiomyosarcoma, even if if they were taking this one out, I'd still probably say, don't risk intraperitoneal spread, even though our algorithm says it's benign.
Yeah, I think they don't do morcellation at all anymore, but I agree, not laparoscopic approach maybe, but this one, we did the percutaneous biopsy, it came back leiomyoma. We know that leiomyosarcomas do not arise from leiomyomas. So if you have a biopsy that shows a leiomyoma, it's not like sampling error. It's not like you're like, oh, wait, but there could be malignant degeneration in another part of it. That's not the precursor lesion. It's like a completely separate genetic origin. So I guess if in doubt, you could do the biopsy, but in this case, it also panned out that the ADC was really not suggestive of a leiomyosarcoma. So yeah, I like this algorithm.
Sabby, I think Nicole said that they're going back to not using the containment bags because it's such a pain in the rear operatively. Oh
yeah. This is actually Nicole's paper. So
right.
Yeah, cool. Okay, one more case. So you guys see anything? This patient had right upper quadrant pain.
Mental
deposits.
Yeah, so we've got some peritoneal nodularity. This is not normal. This is basically peritoneal carcinomatosis until proven otherwise. Less likely things that can cause this include TB, like dry TB, fat necrosis from pancreatitis, but the pancreas is totally normal here. And then any other?
Gallbladder wall is too thick.
Yeah, exactly. So this, I guess, we actually did read this as probably gallbladder cancer with peritoneal disease. They didn't really believe us. This is the, they then put a drain into it. So I guess one of the teaching points is that, just because the wall is thick doesn't mean it's cholecystitis. This lumen is really not distended. It should be greater than 4 centimeters in diameter or 8 centimeters in length. This is just much more suspicious, especially with the peritoneal carcinomatosis, but they did put a drain into it, and here's the drain. And then also now you can see even better on this post-contrast exam, it's doing what gallbladder cancer loves to do, which is directly invading the adjacent liver because there's veins and lymphatics that directly drain into the liver. And we're now developing some intrahepatic lesions. So it was sort of rapidly progressing, and these were intrahepatic metastases. The omentum was biopsied, and this came back poorly differentiated cancer with pancreatic or biliary origin. So just a bad gallbladder cancer, but if you have wall thickening and especially a mental disease, really think about gallbladder cancer.
Okay, so the lower screen is, so she is around in the mid 70s now. This is from 2009, and this is more recent. So I'll just scroll. On this one. I'm not sure if Rupa has shown this case, but. And then this is now. So because it became so large and heterogeneous, I think Rupa was worried when she read this and called this potentially,
Wait, do you have, maybe we can use our algorithm. Do you have, what do you call it, diffusion?
I think so. Here's the diffusion. Let me see that.
It doesn't look very dark. Can you measure the ADC?
Well, it's really not very dark on the diffusion high B values. Well, I mean, there are certain areas, right?
Yeah, but on the ADC, can you measure the value of the darkest part? Like there?
So 900.
Ooh, that was
right. So I guess that would be
actually it's 992. The cutoff was 900. So I'm going to say this is a fibroid.
Okay. But there's one more thing, the reason for showing this. So
it's got blood in it.
It's fat.
Oh.
So this actually turned out to be, this is a path-proven lipoleiomyoma.
Cool. Wait, show me the fat set.
There you go.
Very cool. But okay, so if the fat is in it, you would really not think it's a leiomyosarcoma, right?
No, we were not thinking it's. I just wanted to show not as a leiomyosarcoma.
Oh,
it was because it had become a lot more heterogeneous and larger. So even in the old scan, you can see fat.
Got it. I do have a comment about when you said a couple of times now it got bigger. And that is actually not a feature that we should use to bring up leiomyosarcoma, because fibroids grow just as much and actually more than leiomyosarcomas. So it used to be like that would be, if it's like an enlarging lesion, then we'd be concerned about it, but then you would really be overcalling it because fibroids grow.
Right. But the only thing is this person is 77 years old. So
okay. Sorry. I meant in a premenopausal patient.
You don't expect.
Yes, in a postmenopausal patient, they should not grow. Sorry.
Yes.
Wait, so this was growing postmenopausally?
Mm-hmm.
That's weird.
It is weird, yeah. But
maybe the fat just acts differently than like a regular fibroid.
Maybe it does. The fatty component increased significantly. So
interesting.
But they got the whole thing out, and it was called a lipoleiomyoma.
Very cool.
All right.
Steve had to go to a contrast reaction.
And let me pull up this case. Okay, so we don't have any priors. I'm let me just pause really quick so that I can remove. I'm good.
Okay, so you're
Any
showing
thoughts
us
from
an
anyone? Yeah.
enhancing mass in the presacral area. And are those like ovaries like hyperstimulated? Like they have lots of big follicles?
Yeah, they have lots of big follicles, and there's this polypoid lesion. There's a stalk here that arises from the right ovary. And then you can see this frond-like papillary projection there. And then this is what it looks like on the post-con. Like you said, it was enhancing right
Like
there.
cauliflower-esque.
Very, very cauliflower looking. So I think I put the link, but I'm going to bring over the paper. This was an ovarian serous surface papillary borderline tumor, and that's a C anemone sign. It was the first time I've heard about this case or this condition, and this is what it looks like. So you can reference this paper, and then it's a stalk-like appearance, and they call it like this is, I guess, a sea anemone look. So there's a kind of a stalk, and as not Cookie, Aarti said, this papillary projection that arises from it, and that's called a sea anemone sign.
Wow, that's a really cool drawing too. But your case, did it have like a capsule around it?
Let me move that over. I didn't see a capsule.
Oh, okay, I see.
So this is the stalk, and this is the papillary projection.
Cool. I feel like it looks more like a broccoli or cauliflower or something. I'm not sure about sea anemone, because sea anemone should have like tendrils.
All right, well, you can argue with the individual that came up with the descriptor.
Cool, but it looks like, yeah, like this is a pathognomonic maybe thing for this.
Yeah.
Thing. And these are malignant or what?
I'm.
So she said borderline?
So I just looked up after you posted about this one. It says borderline and it has good prognosis.
Very cool.
Borderline and good prognosis is what I heard.
Yes.
Yes. And right, like the cyst that you showed, does that have like papillary projections inside that cyst as well? The right ovary or ovarian follicle?
Let me share again, 1 second, and we can look at it together. Okay. Okay, you mentioned the right ovary and
like
like here maybe?
One. Yeah. Uh-huh.
Okay, let me look at the post and maybe let me look at the post-con.
Yeah, they are not enhancing, right?
I would say they are. I don't know. Let me look at the subtraction. Yeah, I think they are.
Yeah, okay.
Right there, maybe, and even actually with, I think this is just part of the lesion that's we're seeing it and not plain rather than within that right cystic follicle.
It's a great case, like a textbook kind of case.
Yep. It's funny, so this was a case that our fellows shared with me, and the two fellows were looking at it together like, this is a pathognomonic case of something. and so it's they're like, who would know? Cookie. And so then
that's exactly, I was gonna say, whenever I have like a pathognomonic thing that I can't wrap my mind around, I text it to Cookie.
So then they like put the descriptor on Google and they put Cookie's name, and then they got that radiographics paper.
Oh my God, that's too funny. Okay, Kedar has one.
Okay, so this is just a nice case from a few days back. 64-year-old female with multiple days of nausea, vomiting, and this is the CT Scout. If anyone wants to try.
Bowel obstruction.
Dilated. Yeah. Is it like Gallstone ileus?
It looks like there's like a button or something in the middle of the.
Yeah, that's a button, but so
Yeah, I think Anu got
Like
it.
this.
Yeah. Whoever answered
Gallstone.
got the right answer. It was just, it's right there. And it's right there. So the surgeons refused to believe the residents on call that night. So they called an attending and then they had to take the patient to the OR. So it did turn out to be a laminated stone. It's a great case of gallstone ileus, I think.
Nice. And it has Rigler's triad, which is a biliary air, stone, and an obstruction.
Yep.
Although I think you could even see the air in the gallbladder, right? Right there. Could you see the fistula? Oh, no, sorry. Colon. Let's see.
No, 1 second. Let me just go back.
Yeah, right there. You can see air in the gallbladder.
This one here.
Right there.
Yep.
It's like blending together with the
bowel, yeah.
with the bowel.
All right. It was just a very cool case. Very.
So this patient had abdominal pain. There is this process right here. And I'll show you on the coronal as well. And then there's some findings up here.
The portal vein thrombus.
Yes, good. So we've got some bland looking dark portal vein thrombus here. A little bit going intrahepatic, mostly in the main portal vein, a little bit in the splenic vein. And then we also have this stuff here, and you can nicely see on the coronal that this is what it looks like here.
The thrombus in the mesenteric veins.
Yes, exactly. So these are branches of the inferior mesenteric vein. They're draining this area of the sigmoid colon. So this is basically septic thrombophlebitis. That is like a beautiful example, branching septic thrombophlebitis with like infection, basically abscess in the veins. That's also extending up into the main portal vein up here pretty extensively. And then likely from an episode of diverticulitis. That's usually where these come from. So you can see that there's lots of ticks here. We can't really see like an acute diverticulitis right now, but could have been from that or maybe even colitis from this area. But we thought it was probably from a prior diverticulitis. So just a nice case of septic and when it's involving the portal vein, it's called pyelephlebitis.